Uh, Good evening. Thank you, Namnata ma'am and Mohipal sir, for this great opportunity. And today I'll talk around I'll share my topic, the snare assisted IOL explantation, which is in 2008. Basically, 2008, I asked my video editor to make a clip which I need for my teaching for fellow, uh, and just I asked him to make a simple clip of implantation, but eventually, mistakenly, he reverts the video, and this video give me motivate me think regarding this line: should I remove the lens with the same cartridge? And ultimately, I able to make this new technique, which I called cartridge swallow technique. The instruments are basically very simple. One is modified cartridge, and that is a wire snare, or a now I am doing with the needle with the wire loop or pronil loop. So this is a snare I used, which I developed in 2008 for, which is used to use for the nuclear scatter. Then, and I used for this snare for the IOL plantation. And now I am using this is a simple needle with the loop, wire loop. This is A1 passing wire, and or the 40 purling. How it is made? It is a simple technique. 20 gauge needle tip was blunted with the rubbing with the tuning stone, that is a mosaic stone, and where the two cut end of the wire is introduced into the lumen of the needle, and it is secured by pinches in the needle lumen. You can see this now it is been secured with the simple pinches in the lumen. So how it is made, and you can make a proline wire loop also. You can use the proline also, 40 proline suture, and this is your expander is ready. And how I modify my cartridge? This is A1 A cartridge of the Alcon, the mortar cartridge, and the both side of the cartridge is cut open, so that the tip of the cartridge can accommodate the larger volume. It can open like a jaw of a mouth. You can see this short video clipping, how it is made. It is a cut open the either side almost 2.5 millimeter to 3 millimeter, so that it can open its mouth and it can accommodate the larger volume. And you introduce that expander, and that the expander is ready. This is the picture of expander, and this is a video. This is a there is a IOL of refractive surprise. This is a wrong IOL implanted. So I plan to remove that IOL. This is at only 3 days post-op. We kept for the IOL explantation. So there is no such big addition in the capsular bag. It is better to give the viscoelastic, especially viscoat, into the bag and in the anterior chamber to separate the IOL from the bag. And in this technique, you have to bring the IOL into the anterior chamber, where there is a lot of fibrosis in the capsular bag. You cannot remove that lens into the from the bag. Then it technique will not actually going to happen. This is a technique. It just introduce your cartridge, engage the optic into the inner, and then you just pull very slowly but firmly, and you can see that the whole tip of the cartridge is opening and engulf the lens. The pulse is pulling should be very firm and slow, and the tip of the cartridge should be in the anterior chamber. If the cartridge of the tip should be in the anterior chamber, if it is not in the anterior chamber, it will not get the space to open the mouth. If it is stuck in the in the incision, it will not able to remove the lens because it will not open its mouth. You can see it's a high magnification. Here you can appreciate that's opening of the cartridge, and it how it is accommodated the lens volume. So limitation of this technique, the oil must be anterior chamber. As I said, the where sometimes we need the oil expanded where there is a lot of fibrosis in the haptic. We cannot remove the lens from the capsular bag. In that particular cases, these technique will not. And this is a very unpredictable when the optic size is very thick. So it is very unpredictable when the oil power is more than 27 diopter. This is a particular case. There is also a refractive surprise because there is a post-RK patient, and we eventually, even with the modern biometric formula, sometimes they give sometimes end up with the refractive surprise. The same technique I am applying. The IOL optic is engaged into the loop of the wire, and now I am just in. You can see that I am just introducing the tip more into the anterior chamber and pulling the optic with the air loop, and it gradually folded and come into the cartridge. So you have to be, your pulling have to be very slow and firm so that the cartridge tip gets the time to open and accommodate the IOL. This is another case I want to share you. This is a this is a scaffolding technique which I using nowadays. The here the lens is almost 13-degree diameter, so the lens was a very thin, and antechamber is a patient was a myopic. Antechamber is very deep, so I prefer to do the. Here I am using the Prolink suture loop, and Prolink suture 40 Prolink suture equally effective for this removal explantation of the IOL. Here I engage the optic of the again I engage the optic of the lens into the loop of this Prolink suture, and with the gradual pulling of the Prolink suture, and get time to give the cartridge to open and accommodate the IOL. So this is a technique. This is even you can able to do where there is a no PC support. This is a case I have to remove because there is a lot of iritis, post-operative iritis. Actually, the bulky haptics are lying in the sulcus, so I need to remove that lens. The viscoelastic, that is my preference is viscose, is given to fill the anterior chamber, and again the same technique I am following. The lens is pulling of the lens should be very slow and firm. That is all about my technique. Even it is actually it is very effective all type of hydrophilic and hydrophobic lens in any design. You can see this is a hydrophilic lens of the haptic design. I am using same technique, and that gradually that the whole cartridge is accommodate the IOL and expand the IOL. So far I have did 70 cases I have done, but today's scenario basically very few surgeons is doing this technique. I know Dr. Avaya Zavada is tried this technique successfully, and he praised this technique quite a few years back. But nowadays there's a lot of Carter is available, which is very easier to handle. So I think that's why this technique never get popular. Thank you. Thank you so much for giving me the opportunity. Thank you, ma'am.